हेल- हेलो। ठीक है सर, ठीक है सर, ठीक है सर। हाँ सर, हाँ सर, हो गया, स्टॉप शेयरिंग कर दिया मैंने। हाँ सर, हाँ, ठीक है, ठीक है।
Good evening. Good evening, everybody. I see Dr. Neil, Dr. Piyush Jain, Dr. Radhika, and Dr. Ravindra Kumar. All are there. Dr. Piyush, can we start? Am I audible? Am I
Sir, your mic
audible?
is muted. Dr. Piyush, your mic is muted, sir.
नहीं यार, मैंने किया है, ऑन किया है। प्लीज एक मिनट ठहरो, फिर देखता हूँ मैं। ऑन है यार मेरा माइक। Am I audible?
Sir, yes, you are audible, but Dr. Piyush Jain is not audible.
Piyush, can you put on your
Yeah,
mic?
am I audible now, sir?
Yes, you are. Yes, you are.
So would you
Thank
like to
you.
start? Yeah.
I think we'll start. Friends, we are uh, experimenting again today. And the experiment is that I've asked Professor Piyush Jain from Hindu Rao Hospital and Medical College to conduct the show from his unit. And welcome, Dr. Piyush Jain. And we have Dr. Ravindra Kumar, who's also faculty there, and he looks after adolescent and endocrinology areas in that hospital. May I request sir to please go ahead and start the thing?
Thank you, Dr. Anupam, for inviting us to again start the DIAP program. So today, myself, Dr. Piyush Jain, along with Dr. Ravinder, who is our senior consultant at Hindu Rao Hospital and NDMC Medical College, I being the HOD, we would be presenting a case. Our third year PG, Dr. Neil Mere, would be presenting a case. This 5-year-old boy presented to us with secondary sexual characters. So this was too young. So then we investigated that child. So I'll now, and the findings and the theory would be discussed by Dr. Neil. I'll hand over to Dr. Neil. Dr. Neil, please start.
Thank you, thank you, sir. Am I audible?
Yes, sir, you are audible.
Good evening, everyone. First of all, I would like to thank Dr. Piyush Jain, our HOD, and Dr. Ravinder, sir, for providing me this wonderful opportunity for me to train myself and also to present this wonderful case that we will be discussing today. So before now, let me share my screen. Is my screen visible to all?
Yes, sir.
Maximize it, Neil, maximize it.
Please go to first slide. Neil, go to first slide. Yeah. And kindly maximize the screen.
Okay.
Yes, now it is fine.
Okay. Without wasting any more time, let us get into the discussion of our case here. This evening, I'll be presenting an interesting case of a 5-year-old male child who presented to us with development of secondary sexual characters. I myself am Dr. Kedionil Humere, that's my full name. I'm a third-year primary resident at Hindura Hospital, and the moderator for tonight is Dr. Piyush Jain, our senior consultant in HOD of Hindura Hospital, and also Dr. Ravinder sir, who is in charge of pediatric endocrinology and also in charge of neonatal division of Hindura Hospital. Now starting with the case. We have a 5-year-old male child who presented to us with a chief complaint of progressive penile enlargement for the last 1.5 years, and appearance and growth of pubic hair for the last 1 year, and appearance and growth of axillary hair for the last 1 year. Now, history of presenting illness, as told by the mother first noticed an enlarged testis and penis when the child 1.5 years ago, while she was undressing her child, but she did not think much of it as it was not associated with any localized pain, redness, tenderness, or gross deformity, and she did not seek any medical attention at this time. With time, she noticed gradual increase in the size of the testis and penis, and also appearance of pubic and axillary hair 1 year ago, but thought it to be of a normal growth process. It was until she noticed adult-like pubic hair, which was dark and curly, when she brought the child to the hospital. In retrospect, she also noticed apparent increase in the height of the child as he was taller than most of his friends of the same age. Past history. The mother also reports a past history of seizure, one episode when the child was 3 years of age, for which she sought medical attention from a local doctor and was treated, but no further investigation for the cause was done. The mother also reports a history of aggressive behavior in the child in the form of occasional sudden outbursts of anger towards friends and family members without any provocation, which started at the age of 4 years. There was no history of headache, vomiting, or visual disturbances. There was no history of head trauma, radiation exposure. There was no history of drug intake or ointment application over the penile. There was no history of cold intolerance, dryness of skin, or constipation. Antenatal history. The mother, when she was pregnant with the child, she took adequate antenatal care, and there was no significant antenatal history. Birth history. The child was delivered in a hospital, in a government hospital in Delhi. The mode of delivery was LSA through operation. The baby cried immediately after birth. The baby was a full term. The birth weight of the child was 2.8 kilograms. The length was 48 centimeters. The child was never admitted into the NICU, and the postnatal period was uneventful. Developmental history. Now the child was appropriate for age in terms of development. He is currently in class 1 and has a fair scholastic performance. Immunization history. The child is fully immunized up to date. Nutrition history. The child is on a mixed diet. Total calorie intake per day is 1,410 kilocalories per day, and his calorie requirement for his age is 1,350 calories per day. Protein intake is 22.6 gram per day, and protein requirement is 20.1 gram per day. He is receiving adequate nutrition both in terms of quality and quantity. Family history. The child is a product of known consanguineous marriage. There was no history of chronic illness in the family. The mother had menarche, this is a vague history. The mother gives a vague history of menarche at 13 years of age. Similarly, the father gives a vague history of shaving his beard at the age of 15 years. Socioeconomic history. According to the Kuppeswamy scale, modified Kuppeswamy scale, this family belongs to the upper class. Now, now summarizing our history, we have a 5-year-old boy with early onset of progressive penile enlargement, appearance of pubic hair and axillary hair, apparent increase in height, history of aggressive behavior, and history of seizure. Based on our history, we have a provisional diagnosis of precocious puberty. Under our differential diagnosis, we have kept central precocious puberty, peripheral precocious puberty, atypical CAH, and primary hypothyroidism.
Just
Moving
stop
forward.
here, Neil. Dr. Neil, go back to the previous slide. Yes.
Yes, sir.
Good evening, Anupam sir. And I hope there must be many students, maybe DNB students or postgraduate students who are attending this seminar and webinar. So, I mean, based on the history, there is no confusion. I am Dr. Ravinder. So, based on history, there is no confusion that it's a case of precocious puberty. And diagnosis of precocious puberty is just clinical. No investigation is required to diagnose the case of precocious puberty. yes, the investigations are required just to know what could be the possible etiology. And precocious puberty is not very common in male. Sorry, it's maybe very common in female, but in male, it's quite not that common. And whenever it is there is something organic lesion is usually suspected. And this case is very interesting because 5 years of age, and it is very difficult even for the caregiver or the parents to just recognize that there may be some slight enlargement of phallus, although they have noticed, but they thought it's normal. It is only when there was the pubic hair and axillary hair, they got very suspicious. They thought, what is happening to our kid who is just 5 years old? And I mean, behavior was very aggressive. That was very noticeable because when this baby came to in my OPD, so every time he used to take away our phone, our pen, or something, whatever is there on the table, because he was so aggressive. And being a very small, just 5-year-old baby, you can't say anything to this baby. So this is a very alarming symptoms. So if you are noticing anyone who is coming to your clinic or your OPD and very aggressive in behavior, and this aggressiveness is because of the testosterone. So apart from the autism, it may be something else also. So these points has to be taken care and has to be taken in mind. If any DNB students or any other students, if he's having any other query, can drop the message in the message box. We'll take up all those questions. Thank you.
Thank you, sir, for your input. Now, moving ahead with our case, we move on to our examination, general examination. The child was alert and active. All the vitals were within normal limit, and we did a SMR staging. Now the child has a genital staging of 4 and a pubic hair staging of 4. So we have labeled this the SMR staging of the child as G4 and P4. This is the picture of the child. As you can see, the pubic hair is well developed. It's dark, coarse, and curly, and you can see an enlarged penile here. Moving on. Head-to-toe examination. In our head-to-toe examination, we did not find any acne on the skin, no oily skin. There was no goiter. There is no hypo or hyperpigmentation of the skin, and no gynecomastia was seen. Our anthropometry of our child reveals that the child has a height of 115 centimeter, which corresponds to the 90th centile, a weight of 17.9, lying between the 50 and the 90 centile, a BMI of 13.5, which corresponds to the 25th centile. The father height and the mother height is 168 and 155.5 centimeter respectively. The mid-parental height is 168, and the target range is 162 to 174. Now, with our anthropometric measurements, we find that the child has a height age of 6 years, although the chronological age is 5 years, and the weight age is 5 years, which is appropriate. So we have a child whose height age is more than the weight age, and the weight age is equal to the chronological age. Moving forward. Now our systemic examination was within normal limits. CNS, there was no focal neurological deficits. CVS was normal, respiratory systems were normal, and abdomen was soft and non-tender, no palpable mass, no organomegaly in the abdominal examination. Now, in order to summarize our history and our examination findings, we have a 5-year-old boy with early onset of progressive penile enlargement, appearance of pubic hair, apparent increase in height, history of aggressive behavior, history of seizure, and SMR staging of G4P4, and no palpable abdominal mass. Now, our provisional diagnosis is central precocious puberty, peripheral precocious puberty, atypical CAH, and primary hypothyroidism. Although by now, with our history and investigations, we are more likely leaning towards a central precocious puberty. So we did our further investigations to confirm our suspicion.
Just a minute, Neil. Coming to this, back to the, yes. After taking the history, as Dr. Neil has put forward the diagnosis of precocious puberty, and in DD, what could be the possible etiology, he has enumerated these 4 cases. Then on examination, he just confirmed all those findings which he was suspected. And yes, the case is of precocious puberty. And now, I mean, as per the history, looking like there is a history of seizures, although the case has not been investigated for seizure because this just was the one episode. And so nothing more than that was done, looking like maybe central precocious puberty. However, we should not forget that such type may be a case of atypical CH because in male it becomes difficult to make diagnosis of CH at birth when you have not done the newborn screening. Although nowadays all the hospitals they are doing the newborn screening, even at our hospital, Hindura Hospital, every baby is being screened for 17 OHP and thyroid disorders. But still, because from the way from that background this patient is, he was not screened. So even the atypical CH, they may present as a case of precocious puberty in the later age of life. And third is hypothyroidism. Also, hypothyroidism, although looking unlikely, reason being in hypothyroidism, patient is usually a short stature because he is not having that growth spurt which usually happen in other cases of precocious puberty. So when there is a short stature along with the precocious puberty, then hypothyroidism is only the likely diagnosis. However, sometimes some aberrant presentation may be there. Let us see what comes out after the investigation. Over to Dr. Neil. What are the investigations?
Thank you, sir. Now moving on forward with our investigations. In our investigation, we did our baseline CBC, LFT, KFT, and LFT and thyroid function tests, which were all within normal range. Now, with thyroid function tests being normal, we have ruled out primary hypothyroidism from our differential diagnosis. Now, following this, we did a baseline LH and FSH. As we can see, the values are elevated. Baseline level of LH is elevated and FSH is elevated. With elevated levels of LH and FSH, this diagnosis this findings highly favors our central precocious puberty diagnosis. Within ultrasound whole abdomen which is normal study, ruling out any possible intra-abdominal tumors or any mass. We did a DHEAS, which was normal, which was within normal range. Now we did a testosterone to confirm our diagnosis of precocious puberty, which is, as we can all say, this is elevated. Moving on with further investigation. Now, with our baseline LH and FSH suggesting towards central precocious puberty, we did a GnRH stimulation test. Now, in this GnRH stimulation test, we can see that the LH and FSH values are elevated more than 5 units per liter. This is highly in favor of our central precocious puberty diagnosis. Now with these investigations, we are
Just a minute, Dr. Neil. Dr. Neil.
Yes, sir.
For all of the information, for all the stream gathering, because if you look at the investigation, we just do the primary baseline investigation just to see is there anything organic lesion is going on. However, for precocious puberty, the most important is LH and FSH. If we take the LH, which has been done by chemiluminescent assay, which is usually being done in most of the hospital, so in our hospital also, if it is more than 0.3 milliunit, then it becomes significant. However, the patient or a person who is having puberty very advanced, as in this case, you see it is D4 and P4, means puberty is very advanced. So we expect some more level of LH and FSH. Basically, predominantly, it is LH or luteinizing hormone. However, as we all know that LH is a pulsatile hormone, so every 90 minutes there is a pulse. So we don't know that when we are taking a sample, because when you are taking a sample, that pulse may not be there, so you may not have that high level of LH. However, if you have a very high level of LH, then you think that probably it is the pituitary which has been activated by any means. Is there maybe some organic lesion or it may be some idiopathic situation which usually happens in female. Ultrasound abdomen was normal and testosterone, look at the level of the testosterone. These are the 46 nanogram. At this age, we expect less than 10. So definitely testosterone is high, it means hypothalamic pituitary gonadal axis is active. Means hypothalamus is secreting the hormone which is stimulating the pituitary, and pituitary in return is secreting LH and FSH, which is acting on gonads and producing gonadotropin, testosterone. However, we have to confirm this. So how we confirm? We just stimulate the pituitary. And how the pituitary is being stimulated? We give the same hormone, which is gonadotropin releasing hormone. Although this is not available, so analog is given. So gonadotropin releasing hormone analog in the form of triptorelin or leuprolide. We are using triptorelin, which is given and after certain times, because we know there is a pulse which may be up to 90 minutes. At 18 times that pulse may be liberated. So we are taking 60, 90, 120 minutes sample. Sometimes there may be delayed release of the hormone. So if any time level of LH is 5 or more than 5, it confirms that there is a this is a case of central precocious puberty. Why? Because the pituitary has been stimulated or activated. So that is the case. So now Dr. Neil will further investigate why this pituitary is being activated in this case. Reason being, it is a male. Had it been female, then most likely chances that it is an idiopathic situation. However, in male, it doesn't happen. That too in a very early age, as this is of just a 5 years old. Let us see what Dr. Deal found on further investigation.
Thank you, sir. So far with our investigations and with our histories and clinical features, we have almost confirmed that this is a case of central precocious puberty. However, our diagnosis is still not confirmed. So in order to find out the underlying cause, the etiological cause, we did an MRI of the brain. Now this MRI of the brain, this is a T1 weighted image of the MRI of the brain, which reveals an hypodense lesion in the hypothalamic region, which is highly suggestive of hypothalamic hamartoma. Now with this MRI, our diagnosis is now complete. Now, based on all the following findings that we have now, penile enlargement and testicular volume of 10, having a SMR staging of G4, appearance of pubic hair, which is staged at P4, appearance of axillary hair, bone age. Sorry. Now, I apologize. We have missed over the bone age. Going back.
It's all right, Dr. Neil. You can show here also. It's all right.
Okay. I apologize for that. Now, skipping that bone age with pituitary. Now, the GnRH stimulation test is positive because the LH value was more than 5. And there's an apparent increase in height as reported by the mother. Now, our final investigation, which was MRI, which revealed an hypointensity in the region of the hypothalamus in T1 weighted image, confirmed our final diagnosis. Now we have a complete diagnosis of central precocious puberty, and the cause was hypothalamic hamartoma. Now, with the diagnosis, we move on to the treatment of the case. Treatment. The treatment is GnRH agonist. The principle of our treatment here is to provide continuous exposure of GnRH, which will ultimately suppress the hypothalamus pituitary gonadal axis. For this child, we gave leuprolide 3.7 mg subcutaneously every monthly. Now, because this is a case of hypothalamic hamartoma, surgical cases are
just a minute, Dr. Neil. There are two options to treat this case. Either we can give monthly or 3 monthly. We usually prefer 3 monthly. Dr. Neil, it was the case where the leuprolide was given 11.25 milligram 3 monthly. Reason being, compliance become better. It becomes difficult for a patient to come every monthly. So although we started with 3.75 monthly, but just after 1 month, we shifted to 3 monthly regime, because that is also a recognized and acknowledged treatment in a better form of compliance become better. And hypothalamic hamartoma, although it's a tumor, but it's a very benign tumor. So there are a couple of indications for surgery which Dr. Neil is saying, telling. If that is not there, then it is being this precocious puberty is being treated till the age of puberty, and rest of the things is left, which usually resolves or doesn't cause any problem in the future. Dr. Neil.
Thank you, sir, for your corrections. So surgical cases for hypothalamic hamartoma are reserved for cases which have cases with progressive neurological deficit, which was not found in our case, hydrocephalus, which was also not found in our case, progressive enlargement of the mass, and intractable seizures. Our case had only one episode of seizure at the age of 3 years, following which there was no more seizures. So for our patient, we started on leprolide 3.5 mg monthly, then switch over to 11.2 every 3 monthly. Now, that is the end of our case. Now we move on to the discussion of our topic. So under discussion, we have subheadings: physiology of normal puberty. We will be discussing about that. We will also be discussing about the definition and etiology of precocious puberty, and also our approach to precocious puberty and management. Now, physiology of puberty. Now, puberty is regulated by the hypothalamus pituitary gonadal axis. This axis receives stimulatory signals and also receives inhibitory signals. It receives stimulatory signals from neurotransmitters such as glutamic acid, kisspeptin, and inhibitory signals from GABA, dopamine, and MKRN3 protein. Now, the hypothalamus pituitary gonadal axis remains dormant until the age of 8 to 9 years of age. Now, after this, 1 to 3 years before puberty, luteinizing hormone becomes detectable during sleep, and this luteinizing hormone is secreted in a pulsatile-like fashion. Now with time, as the child approaches puberty, the amplitude of LH increases, but the frequency decreases. By mid-puberty, the LH pulses becomes even during day. Now, as you can see here in this flow diagram chart which I've made, the hypothalamus receives stimulatory signals and inhibitory signals. Following this, the hypothalamus will release gonadotropin releasing hormone, which will act on the pituitary. Now the pituitary will release LH and FSH. LH in males will act on the Leydig cells to produce testosterone. LH in the females will act on the theca cells to produce androstenedione. Now FSH, once produced from the pituitary, will act on the granular cells, converting the androstenedione produced by the theca cells to estradiol. And in males, FSH will act on the Sertoli cells to produce inhibin and antimullerian hormone. Now, these sex hormones are responsible for the development of secondary sexual characters, growth spurt, and maturation of bone. Now, definition. Moving forward, we have definition of precocious puberty. Precocious puberty represents pubertal onset 2 standard deviation earlier than the population norm. Now, this translates into breast or pubic hair development before the age of 8 years in girls, or testicular or penile enlargement before 9 years in boys. Now, in cases of delayed presentation, breast stage above 3 before 9 years and breast stage 4 or menarche before 10 years is suggestive of precocious puberty. Now we move on to the etiology of precocious puberty. The etiology of precocious puberty in females and the etiology of precocious puberty in males. Precocious puberty in females can be incomplete or can be complete. It can be a case of isolated thelarche, pubarche, or menarche. In complete cases, complete meaning that all the secondary sexual characters are affected, meaning you will find thelarche, you'll have menarche, you'll have thelarche, pubarche, and menarche. So in complete precocious puberty, we have central causes and we have peripheral causes. Under central causes, 80 to 90% of the cases are idiopathic, and organic central causes include CNS lesions such as hamartoma, glioma, hydrocephalus, arachnoid cyst, genetic causes such as mutation in the KISS1 receptor, MKRN3, and DLK, insults such as radiation and infection. Under peripheral causes, we have McCune-Albright syndrome, hypothyroidism, cyst tumor. Under peripheral, we have adrenal tumor, excess aromatous exogenous, Peels-Jeghers syndrome. Precocious puberty etiology in male, 50% of the cases are central and 50% of the cases are peripheral. Now 50% of the central cases, out of this 30% are idiopathic and 20% will be organic. Organic causes includes CNS lesions such as hamartoma, glioma, hydrocephalus, and arachnoid cyst. Under organic causes, we have genetic, same as females, KISS KIS1R receptor mutation, and KRNR3 mutation. In cells such as radiation infection, under peripheral causes, we have adrenal. As sir was pointing out before, we have 21 hydroxylase deficiency, 11 hydroxylase deficiency, and we have carcinoma, adrenal carcinoma, and testicular tumors. We have testicular tumors, we have HCG secreting tumors, and we have testicotoxicosis. Next, our approach to precocious puberty. Now, approach to precocious puberty is something as such. First of all, with definitions, we know which cases to suspect. After any patient which comes to our OPD, which fulfills the criteria of precocious puberty, once we have confirmed precocious puberty by that, we have to confirm whether it's central precocious puberty or peripheral precocious puberty. Now, there are certain pointers towards central precocious puberty in females. Some of the pointers towards central precocious puberty in females are: central precocious puberty in females will be rapidly progressive. They will have onset. They will have onset before 6 years of age. Breast age can be developed. Will be rapidly developing. And then the basal LH will be more than 0.3, and the bone age will be advanced. And then they'll have uterine volume. If you look at the ultrasound pelvis of the female, you have uterine volume more than 2 ml, uterine size more than 3.4, and the uterine thickness will be more than 3 ml. Such are the features of central precocious puberty in female. Now, in male, some clinical pointers towards central precocious puberty are: central precocious puberty usually will present with an enlarged testis and enlarged penis, whereas in peripheral causes, the testicle volume and the size of the penis will be decreased. This is a very important clinical pointer towards central versus peripheral. Now, in the above diagram, we can see this is an approach to precocious puberty in females, and this is an approach to precocious puberty in males. In females, if a patient is suspected of precocious puberty, we have to identify whether this is a case of complete or this is a case of incomplete precocious puberty. If it is a case of isolated puberty, then we have to think about adrenal tumors. For this, we have to do a DHEAS level. If the DHEAS level is less than 40 microgram, this is suggestive of puberty and not of adrenal cause. If the DHEAS is between 40 to 135, this is suggestive of adrenal. And if it's more than 135, then this is highly suggestive. And in this case, we should do a 17 OHP and imaging of the abdomen to rule out any adrenal tumors. Next, in complete thelarg, we have to look at the bone age, because precocious puberty is very closely related with bone maturity. So if we have a normal bone age and it's slowly progressive, in such cases, if we have a case of complete precocious puberty and we have an advanced LH, and the bone age is advanced, then we have to do a luteinizing hormone. If the luteinizing hormone is more than the basal level is more than 0.3, then you have to do an MRI to rule out any central causes. And then you have to, if it is less than 0.2, then you have to investigate the peripheral causes of central precocious puberty. Now, the approach to precocious puberty in males. If a male child presents to us with a precocious puberty, the baseline LH has to be done, and if it is more than 0.2 mu per L, as it was in our case, we have to do an MRI head. Now, the MRI head will give us a definitive diagnosis. Now, if the LH is between 0.2, if the LH is equivocal between 0.1 to 0.2, then we have to do a GnRH stimulation test. And following the GnRH stimulation test, we will be able to further find out the source of the diagnosis. The next is, if the LH is less than 0.1, then this is highly suggestive of a peripheral cause. And in this situation, we have to rule out adrenal carcinoma, and we have to do a 17 OHP level to rule out congenital adrenal hyperplasia. Now, moving on to the next slide. Now, our management of precocious puberty. Our goals in management of precocious puberty are age-specific pubertal development. We want normal growth and we want to avoid side effects. Under our management treatment, we have GnRH analogs. Now, indications of GnRH analogs: girls with onset of precocious puberty before 6 years, or girls between 6 to 8 years with an advanced bone age. And advanced bone age is defined as bone age more than 2 years above the height age. Now, the indication in boys is all boys with precocious puberty are indicated for treatment because they present later than girls, and they have greater bone advancement. Now, our treatment options, GH formulations. We have leuprolide, which also used in our case. We have goserelin, we have buserelin, we have triptolin, and we have hystrelin. Leuprolide and triptolin are locally available, and we use these two medications for our patients. Following treatment, it is essential for us to monitor our cases to see whether there is an effective response to treatment or is there any side effects to the treatment. Now, our clinical assessment includes anthropometry to be done every 6 monthly, SMR staging to be done every 6 monthly, and bone age to be done yearly, ultrasound pelvis in cases of female to be done yearly, and post GnRH, LH. After 2 hours of GnRH, we have to check the level of LH. If it is less than 5, if it is less than 5, this means that if it is less than 2, if our post GnRH is less than 2, this is suggestive of inadequate treatment, and there is a need to increase in the frequency of medication. I apologize, this is a typo here. Sorry about that. This is a typing mistake here. It should be less than 2 milli international units per L. Now, following monitoring of our treatment, we have our duration of treatment. How long do we give our treatment? If it is in case of a female until 10 years of chronological age or bone age of 12 years, and until 12 years of chronological age in boys. Now, with our treatment, GnRH analog treatment increases the final height by 1.4 centimeter per treatment year compared to the predicted height. So with this, we have come to an end of our presentation. Now I give the time over to Dr. Ravinder and Dr. Piyush.
Thank you, Dr. Neil. It was a very good presentation. Also, we have to take care in these cases of precocious puberty, specifically at this young age, that there would definitely be some behavioral problems. The child would be at risk, and there would be other risks, which shows that there is a link between early puberty in girls, and also there is a slight risk of increase of breast cancer later in life. So we have to take care. So we have to take care of all these problems in these children also. So now I hand over the mic to Dr. Ravinder for a follow-up. Dr. Ravinder?
I think before me, let me hear the comments from Anupam sir. Anupam sir, because was just pitching in between. Anupam sir, are you there?
I'll switch on my mic. Yeah, I'm there now. Can you hear me?
Your comments on case and anything you think should be explained or needs to be explained.
I think the case was very nice presented, and the explanation for each step has been very nicely delineated. One more thing is the psychological support which we have to give to the parents and to the child for a condition like this. That also is a part and parcel of the treatment, which we tend to forget at times. I think that is very important. Dr. Ravinder, please take over so that.
Very true. Pointed out, sir. And because, puberty is the most important phase of our life. So puberty is needed for this world to go on, life to go on. However, if it is coming early, then it becomes a problem. So during that phase, a psychological support to the parent and to the patient also, because many of their behavior may fit well into adolescent behavior, may not fit or suitable for a child of just 4 or 5 years of age. And secondly, we should be very cautious while treating these cases of precocious puberty. Reason being, when they are occurring early, means less than 6 years, then most likely there may be some organic cause. Hence, MRI is needed in all these cases. However, now, because of the secular trends, because of the nutritional status of India is going up, because we are now moving towards a developed nation category, now somehow, probably, the age of puberty is shifting low, means somewhere closer to maybe less than 8 years. However, still nowhere in the world the diagnosis has laid down or come down to 6 or 7 years, despite there are some talks, especially in US, what they have seen in US Black and Hispanic population, that probably they are females, they are getting thelarchy even at the age of 7 years. However, still we proceed to diagnose and investigate a case who is having precocious or secondary sexual character with less than 8 years of age. So when we are dealing with a case who is between 6 to 8 years, we have to be very cautious and somehow conservative while dealing with all these cases. Less than 6 years, naturally, that require exhaustive investigations. Any other questions if are there in the chat box or anywhere anyone wish to ask? We are there to clear the doubt.
Dr. Ravinder,
Yeah, I have a comment. So right now we also have another drugs like Histrelin. We talked about GnRH analogs. This is also one of the latest GnRH analogs. This can be implanted, and once implanted, this will act for about a year or so. But this is right now not available in India. And
Very
this
true,
can be
Dr.
given
Piyush.
between 2 to 9 years.
Yeah, it is being used in has been used in US. However, what has been seen, if you look at the response, this leuprolide, which is being given once in 3 months, is a cost-effective number one, having the minimum side effect and giving the very good results. Hence,
Exactly.
even in US, because for giving the Histrelin, you require surgical procedure because this
It needs to be implanted.
drug has to be implanted. So that is why still the drug of choice is leuprolide. Just and it is all right.
Dr. Ravinder,
Question from Dr.
Dr. Ravinder,
Varghese.
can I just pop in here for a second?
Yes, sir.
Yes, sir.
Yes, sir.
Would you like to elaborate on endocrine disruptors and its impact on female thelarchy and this thing? Is there any relationship to that?
Yeah, yes, sir. Very good, very good question, sir. Now there are so many things in our diet or in environment which act as endocrine disruptors. There are lots of theories, especially while we are taking couple of type of foods, that these may act as endocrine disruptors and may cause early initiation of puberty rather than the true precocious puberty. However, all these things are just you can say all either in research mode or just it's a hypothetical association are being said. Many things which are put in food or in environment. So they have been labeled as endocrine disruptors. However, still there is no consensus statement from endocrine society that these are the foods or these are the preservatives used in the food material that should not be used who can cause precocious puberty. Early initiation of puberty, yes, maybe.
Well, so there are a couple of questions which have been asked from the listeners. These questions come from Dr. Varghese. Is there any role on 17-hydroxyprogesterone to diagnose CAH in such cases? Is question number one. Number two is, can we use GnRH agonist for isolated thelarchy? Dr. Ravinder.
So if we are keeping possibility of CH, atypical CH, yes, 17 OHP is definitely should be done whenever we are thinking and we are getting not adequate result in favor of central precocious puberty. Then we move over for diagnosing atypical CH. Apart from 17 OHP, if this is because atypical cases, we may need ACTH stimulation test. Second question was?
Can we use GnRH agonist for isolated thelarche?
GnRH agonists are very costly. Number one, has to be given. These are the GnR agonists only we are giving. Leuprolide or histoline, all these are GnRH agonists. I think he's asking about antagonist. Or the question is about agonist. Because agonist, obviously we are using agonist.
Can it be given for isolated thelarche?
Isolated thelarche usually doesn't require any treatment. It's a benign situation. Usually comes around about 2 to 3 years of age, then goes out and on. When you investigate these babies, usually they have FSH predominant response rather than the LH. LH is usually just 1 or 2 after stimulation in such cases. FSH would be high. So the treatment advised for isolated thelarche is just wait and watch. It will be all right. And they do not have any other complications, neither any compromise in the adult height nor any other complications.
Are there any other questions? Because I can see only these two questions in the chat box. There are about 39 participants. Would you like to ask anything else? Otherwise, thank you, Neil. Thank you, Ravinder. I'll hand over the mic to Dr. Anupam for winding up. Dr. Anupam, sir, you are there?
Yeah. Sorry, my mic was muted.
Okay.
Thank you very much, Dr. Piyush, Dr. Ravinder, and a good presentation by Dr. Neil deserves all the appreciation for that. Thank you once again, and we hope to sort of increase the presence of other institutions in this case presentations also, because it will add to the variety of the cases and to the variety of the moderators who will be doing the presentation. Thank you once again, all of you, and good night to everyone. Thank you.
Good night, and thank you all. Bye.
Good night. Thank you all. And thank you, Anupam sir, for a very nice initiative. I think it's a good platform where I think we should take all the DNB Institute on this platform. We should do something in that area, that contact, and if everyone is presenting and all of us are learning, because it's a learning for all of us when some other institute is presenting the case.